Good evening, everybody. On behalf of the Emirates Society of Ophthalmology, I would like to welcome you all to our webinar on glaucoma management. We're going to be talking about the A to Z of glaucoma management. This is a part one of the series, so we're going to stick to things which we're going to be doing in the outpatient setting, in the OPD itself. We're trying to keep it simple and basic, and so I'm sure that there are lots of esteemed colleagues amongst us. So we just thought it's better to start the basics and then build it up from there. This evening, I'm joined by two of my esteemed colleagues who I'm delighted to have. Dr. Omnia Hamam. There's very few people who would not know her in the circles of ophthalmology in the UAE. So Dr. Omnia is a consultant ophthalmologist at the Zayed Military Hospital. She's had a fellowship in glaucoma and retina from the Père Marie Curie University in Paris. And she's an adjunct professor in the UAE University and the head of and most importantly, the head of scientific committee of the Emirates Society of Ophthalmology. She is very passionate about glaucoma. She is French board certified, has had 4 university diplomas in glaucoma, retinal imaging and pathology, neuro-ophthalmology, as well as ocular inflammation and infection. And she's always very eager to learn, to keep talking about glaucoma, keep involving people around her, and so enthusiastic. So it's such a joy to see her working, because she's, when you see her around, the future of glaucoma in the UAE is bright. So it's a pleasure to have you, Dr. Omnia. Thank you. My other colleague is again Dr. Ankita. She's going to be speaking the talk after mine. So Dr. Ankita Chaudhary has joined us at Vista Healthcare. After she had finished her training, her residency in India, she had a fellowship in a very busy cataract surgery center in India, followed by senior residency in various regional institute in Haryana. Following that, she trained under Dr. Kavi Mansouri at Lausanne, where she did a glaucoma fellowship. While in Lausanne, she also got the opportunity to work with Dr. Andre Mamou, and that's really where her glaucoma specialist journey has started. And well, if you are with someone as specialist, Dr. Andre Mamou, then you are going to be exposed to deep sclerectomies, to Zens, to Kahoot blades, SLTs, laser hydroplasties, and that's where her talks this evening are going to be. It's going to be on lasers and glaucoma, which will be the concluding talk this evening. So it's a pleasure to have you here as well, Dr. Ankita, and welcome to the UAE. So
Thank you, Prashant. Thank you so much.
Thank you. So if we can get started with Dr. Omnia's, please. Dr. Omnia will be giving the first talk on guidelines in ophthalmology. So Dr. Omnia, if you could start sharing your screen, please.
Okay. Thank you so much, Dr. Prashant, for this presentation. And always, we are so happy to work with you. We are working a lot in the glaucoma field together. I used to send him the patients when I'm stuck. And thank you for your help all the time. Okay, I'll talk about which guideline we have to follow in glaucoma management. As Dr. Prashant, he says, our meeting today is from A to Z in glaucoma management. And to manage our patients in proper way, so we need to be sure that we are diagnosed, give the right diagnosis. And really, we need to follow the guidelines. And we are talking the guideline. We just, a lot of my colleagues, they keep asking about the guidelines. There's a lot of guidelines, but I choose actually the most important, maybe guidelines we need to follow. I used to name them as habits. So which habits really we need to apply in our daily practice, which are related to those guidelines and recommendation, and which will lead us for the best glaucoma management. So the first guideline or first recommendation, the applanation tonometry. So we know that it's the only, you are seeing the patient, and it's the only factor which you can manage or you can modify during your visit. So all of us, the first thing we are looking for, it's always the intraocular pressure. And all the studies and the big trials shows that it's the only modifiable risk factor for progression, and it's the only thing which we can change. And in another study as well, in Canadian glaucoma study, they shows that every 1 millimercury increase in intraocular pressure during 5 years can increase the risk of progression by 19%. So it means that I have to be sure that my intraocular pressure is well measured. And this is the first recommendation. We'll talk about the Canadian Society of Ophthalmology, who I recommend that the most, that the applanation tonometry is not the air tonometry. The applanation tonometry is the most reproducible method to measure the intraocular pressure. As well, the European Glaucoma Society, they encourage to use the applanation tonometry, and there is no other really alternative way to measure the ocular pressure. Of course, if we have a normal cornea. Now we are talking about normal cornea. And all the correction nomograms which exist, and a lot also of colleagues, they keep asking us about this nomogram. Actually, none of them been recommended or sure to be used so far. So the Canadian Society, again, of Ophthalmology says that intraocular pressure should always be communicated as measured IOP rather than corrected IOP. So this point we need, because we keep asking all the time about this table, you know, or how to measure it from air to ocular pressure applanation, or how to correct it according to the central corneal thickness. International Council of Ophthalmology as well, they recommend to measure the ocular pressure before doing any gonioscopy or dilatation. So now we have two main recommendations regarding the intraocular pressure. It has to be measured with applanation tonometry. It has to be, we don't need to apply our nomogram or our table to just modify the ocular pressure according to the central corneal thickness. And the documentation here, it's very important. You need to document which method you use. Let us say that you use the air, still you have to document it this way. You have to put the time you measured your ocular pressure of this patient, the central corneal thickness, and with which medication. So this is the best way to follow the intraocular pressure changes later on. And here is some copy of my files before also. So I used to write the way how I measure the pressure, the time, and with which medication, and of course each eye separately. Second recommendation, the gonioscopy. The gonioscopy and repeat gonioscopy. So no glaucoma management without doing gonioscopy. This case of one patient being seen in 2007, and his visual acuity was 6.6 with ocular pressure of 17 millimercury in the left eye and 18 in the right eye. He was on maximum medication with normal corneal thickness, and he was doing well. If we are talking about pressure now, in 2017, we repeat the gonioscopy, and we found that the angle was totally closed, and his hand movement. The pressure is still normal, and every time he's coming, just we check the ocular pressure, but no, the gonioscopy never been done. While this patient, he has bilateral closure angle. So gonioscopy is the gold standard technique or method to rule out any closure angle glaucoma. And there is no glaucoma management without doing gonioscopy. And here I think Dr. Ankitashi will talk later on about the peripheral iridotomy. But just to say here that many studies and papers published showed that after peripheral iridotomy, still we can have from 19% to 81% of patients still with closure angle, and still they can develop acute angle closure even from 5 to 7 years later on. So there's 30% of risk of developing closure angle glaucoma even after peripheral iridotomy. So this means that we need to repeat the gonioscopy. And here the recommendation, here just I'm saying that the 10% of the cases we are seeing every day, they have narrow angle. And here the recommendation that the Canadian Society of Ophthalmology says that no classification of glaucoma without gonioscopy. The International Council of Ophthalmology as well, they recommend to do the indentation gonioscopy. So just identify, we have to identify if this closure is synechia or oppositional closure angle. So it means it's really important to do your gonioscopy. European Glaucoma Society as well recommend for all suspect and ocular hypertension patients to have gonioscopy examination. European Glaucoma Society again considered Van Herrick as a very useful method if gonio lens is not available to screen glaucoma patients. Our third habit or guideline, set your target IOP. We keep talking about set your target IOP. It's really very, very important to know that we have from first to have an idea about the desired ocular pressure. And here the European Glaucoma Society and the Canadian also Society, they recommend to document this intraocular pressure, and the target IOP is the upper limit of the IOP. Just we'll explain it later, because the IOP, and each eye has to be measured separately. Yeah, this is one point as well. Each eye has to be measured separately, and it has to have its own target IOP in each eye. So for this table, I think you saw it already before, how we can set our target IOP. So I have to take in my consideration all my patient, she's old. If she's old, so the life expectancy, it will not be that longer. And if she has at the same time early glaucoma changes, so I'm fine to put her in the higher target IOP. Patient who come with 30, 20 or 9, if he has and the rate of progression, which we'll talk about it later on. Some patients, they progress faster than the others. And so the patient who progress faster, it means that I have to go to the lower side. And of course, we have to consider also always the central corneal thickness. And remember that the target IOP has to be documented for each eye separately. And this is an example, case 1, patient with 35 years old, male, secondary glaucoma, post-ocular trauma, pressure 32, mild early visual field defect, and mild cup disc cupping. So we will take him to we can accept the 20 to be 20/21 or to be 19. Other patient with advanced visual field defect, so we have to take him to the lower side. So achieving the target IOP, we have to keep ask ourselves if we achieved our target IOP, and we have to re-evaluate this target IOP, because we need at least 2 to 3 years, or actually every 2 to 3 years, we have to repeat and to study the progression and to reset our target IOP. Fourth habit, follow the guidelines in glaucoma treatment. Start with monotherapy, either prostaglandin or any other monotherapy. And if you want to choose your monotherapy according to the guideline, you have to study the patient, his adherence, his quality of life, if he has any systemic diseases, and you have to study also the drug mechanism of action, the efficacy, and the cost. Before we used to say the prostaglandin, yes, it is maybe the maximum reduction of intraocular pressure, but now all the societies or all the recommendation allowed us to use any of anti-glaucoma agent as monotherapy to start with, as first line of treatment. But we have to study our patients. Here, the first choice, as we said, so it is monotherapy. And now I have to see if the patient is tolerating the medication and I'm achieving my IOP. If he reached the IOP, it's okay. So I have now to continue following him with visual field, optic disc, ocular pressure, and if he's tolerating well, so it's fine. If it's not tolerated and the IOP is not effective, the reduction of the IOP, so in this case we have to switch between the monotherapies or to consider laser. We add second, this, I think so Dr. Prashant will talk more about this part. And so we have to remember that we need to switch between medications or between even the same class of monotherapy. If I don't reach, if still I didn't reach my target IOP, I will add here the second drug. And this is also one of the main recommendations of the European Glaucoma Society, that drug considered as inefficacy if reduction less than 15%, switch between medication, and remember the period of washout when you switch. Okay, so this is maybe I think Dr. Prashant will talk about, but there's a period of washout when we switch between medications. So we can judge on the second medication if effective or not. One of the main complications, and it's very important, the intolerance or the corneal the ocular inflammation with our glaucoma medication. Unmet needs in glaucoma. So here the European Glaucoma Society recommend to examine the ocular surface and to consider in the clinical management of patient the ocular surface as well. And here they recommend to use the preservative-free formulation if it's available. So if you have the choice to use your monotherapy and preservative-free, so this is the best choice. Avoid, and here the Canadian Society also, they recommend to minimize the number of medications, so avoid many medication. We have a lot of patients who come with 3 medications from the first time, and we keep them on 3 medications from the first time. No, even if the patient he presents to your clinic with high ocular pressure, try to, for the second appointment, try to reduce or remove 1 or 2 of medication and to stabilize him on 1 medication. So many medication is equal problem of adherence, and at the end, patient he will develop ocular inflammation and he will not use the medication. Here we'll talk about also the fixed combination therapy. The most important thing in this slide, that the fixed combination therapy is not the first line of treatment. We add it to reduce the pressure if the monotherapy is not enough. So it's not first line of treatment. Laser trabeculoplasty now considered as first line of treatment according to the guidelines and according also to the LIGHT study, the laser in glaucoma and ocular hypertension patients. So laser trabeculoplasty shows a high efficacy equal to the medical treatment. So think about the laser trabeculoplasty in your practice, please. This point also is very important, this guideline, this recommendation to dilate the patient, dilate at least 1 time. Dilate to check the lens and to check the disc and to study the nerve fiber layers and to study the fundus. You cannot see the pseudoexfoliation without dilatation. Many times we missed it a lot because we never dilate the patient, or we didn't see the patient while he's dilated. And such patients, they come, the pseudoexfoliation, remember that pseudoexfoliation patients Many of them, they come with normal or even low ocular pressure. I mean, not low, but normal ocular pressure, which is not expected, but they have peaks. So you have to dilate them to make sure that you don't need them to be more lower. So pseudoxylation, you have really to set low ocular target IOP. You have to check. So we dilate to examine well the fundus, and to make sure that we don't have any retinal problem, which can affect actually the perfusion to the optic disc, or which can affect our visual field. Rate of progression. You have to know your patient. The rate of progression is an important part of patient management. And this thing, we cannot know it on the first visit. So we know it most of the time, all the time. So we set the target IOP, and here we have to study our patient. This diagram, maybe you saw it a lot. This actually shows the, A here, the line, actually the effect of age only. A is patient, or it's a person without glaucoma. So this is the effect of the age on the ganglion cell layers. And then we have B patient, and those are glaucoma patient, and C patients. One diagnosed later on the life, so old patient, and C patient diagnosed earlier, but one of them progressed more than the other. So C patient, who's younger, he has severe functional impairment problem. And here when we come to D patient and E patient, both of them, they diagnosed early, but one of them progressed more than the other. E patient progressed faster, so he has severe functional impairment, visual impairment at early age. So it's totally different. So we have to study each patient separately. And the method to detect, of course, progressions, the IOP, visual acuity, the visual field, and the rate of progression here, the EGS recommend 3 visual field tests per year for the first 2 years. So you need to do three visual field every year for the first 2 years. Then you can do it less with the time. And here in this table also, they recommend for the glaucoma suspect, you can do it once or twice per year. Early glaucoma every year. Moderate glaucoma, it will be every 6 months. Advanced glaucoma, we need to do for them more frequent the visual field. And the 7th habit, which is the last one, glaucoma alert. Be alerted, you know, your patient, you have to have this sense when your patient just start to progress. Sometimes they progress slowly, and sometimes we miss their progression. Here, I want you on the slide just to remember that the ocular hypertension study patients, 55% of them, the optic disc changes appears before the visual field effect. And in the early glaucoma patients who has glaucoma, and in the early management of glaucoma patient study showed that the progression started with the visual field. It means that sometimes the progression can start with visual field, and sometimes can start with the disc changes. A stable patient, so we can continue. Unstable glaucoma, we need to add more medication, and they need to follow. This is my last slide. How to apply, I add this slide at the last minute because I know this question also been asked a lot. How to apply the main glaucoma trials in my daily practice. We have this all trials. I put in red the trials which do you need in your daily practice in the clinic. So the ocular hypertension, their question was to treat or not to treat, and they studied the risk factors. And I highlighted the most important things, I think so. 6.4% of the patient who wasn't treated, were treated, I mean, didn't have glaucoma. So actually they had glaucoma, sorry. So actually if you have 100 patients of ocular hypertension and you treated 6, you have the chance that 6 of them can develop glaucoma. And this is what we called NNT, which is number need treatment. If I treated 100 patients ocular hypertension, 6 of them might have glaucoma. One more thing, 50% of glaucoma start with disc changes. This is what I mentioned before. This study mentioned that. And the main risk factors here was the central corneal thickness as a very important factor. In the early management of glaucoma, the question was immediate treatment. I have today early glaucoma changes. Do I have to treat today? So, and they studied also the risk factor. The most important point here that every 1 millimercury less will give you, if you reduce 1 millimercury less of pressure, so you have less 10% chance to develop glaucoma. And one point also, which is important, that progression happen even with treated patients early and 25% after 5 years. So it means that the glaucoma patient, they progress. We have to follow them seriously. Normal tension glaucoma, the main question to treat the normal tension or not, and the nature of normal tension glaucoma. And the main thing here that patients treated, they have they progress less, and the progression was slow and localized over 7 years. So just to learn that normal tension glaucoma, we need to study the patient as well. No rush to treat the patient, but we have to put in our mind that they also progress, but very slowly and localized. So we can take time to study normal tension glaucoma. And in this study, we learned that most of the normal tension glaucoma females with migraines and vascular problems. The other studies, surgical studies, so maybe it's not the time to talk about them. And the LIGHT study, which is compare the SLT with treatment. And we have the answer now that SLT can be considered as first line of treatment. More frequent follow-up is suggested in the presence of advanced disease, multiple risk factors, and progression. Conclusion, assess each eye individually. Set target IOP, start with monotherapy, reevaluate target IOP every 6 months and after 2 to 3 years. I took, I think, long time. Thank you so much.
I think it was a very comprehensive opening, so that was very nice. You know, in cricket, we say the opening is strong, then the match is good. So I'm happy with this. It was a very nice talk. Thank you. I liked a lot of points that you made. One of them, and I think that's one of the most basic ones, was about the intraocular pressure measurement, because the number of glaucoma patients, I'm not even going to talk about non-glaucoma, but number of glaucoma patients who we see are treated based on APPLANATION and non-contact tonometry is so high. And really, they're just not as accurate as APPLANATION. So I think APPLANATION, eye care, Perkins, these are the way to go of non-contact. I completely agree with you in the points that you made about how you go about assessing your patient and how you set your target IOP. In my practice, I like to rely on fundus photographs a lot as well. So when I dilate the eye, since we have the fundus camera, we just take a picture and keep, even for glaucoma suspect, not just glaucomas, but for those myopes or for those normal looking discs, I don't know 5 years down the line whether we will still have the OCT with us or not, or if the OCT is going to be still the same. Will the next web source talk to my spectralis of today? I don't know. But the fundus photograph will always be there. And I think that's just one little tool that I love to use. But yeah, fantastic talk. Thank you.
Thank you.
So I think let's go ahead to, let's keep the discussion for the next talk, and let's just go ahead with my talk. Let me just start to share my screen, please. Okay, let me just get this here. Okay, so, my talk today is on medical management of glaucoma as we see it this year, as we see it now, because drugs like pilocarpine, believe it or not, was discovered in 1873. It's been 100 years or more that pilocarpine has actually been used in glaucoma. So I thought, instead of going through the regular talks, I thought it's easier if I just talk to what's relevant to our practice in the clinic today. I will be mentioning a lot of names of drugs, and I've tried to be as even as I can. There are no financial disclosures. So glaucoma, as we know and as we heard from Dr. Omnia's excellent talk, is a progressive condition. It's pressure sensitive. So I don't like to say high or low pressure because any of the, it's just sensitive to the pressure level it's at. It's a chronic optic neuropathy with loss of retinal ganglion cells, a specific pattern of optic atrophy, and a characteristic visual field loss. Now, the goal of our glaucoma management should be clear in our heads as a glaucoma as a physician, that we need to maintain the visual function for the patient's lifetime. That's what Dr. Omnia was also alluding to, that we try to assess what the what the life expectancy of a patient is. I tend to put the life expect in my head. I tend to put everyone's life expectancy as 100 and work from there. So, and the therapeutic intervention that we do should affect the patient's quality of life to a minimum. Now, the major group of glaucoma medication that we have today are prostaglandin analogs, carbonic anhydrase inhibitors, alpha agonists, beta blockers, miotics, and hyperosmotics. So in terms of best pressure control, prostaglandin analogs give us typically a 30 to 35% reduction in pressures. Beta blockers coming in next with about 25 to 30%, and CAIs and alpha agonists roughly give you, as well as miotics, roughly give about a 20 to 25% reduction in IOP. The choice of the drug would depend on what my target IOP would be, what the health status of the patient is, whether the patient's an asthmatic, whether there are any contraindications, whether the patient's a child, for example, where we can't use alpha-gan brimonidine, whether the drug is available in the country. That's something as glaucoma practitioners, all of us are so aware of now, and I'll come to that point again in the end, where drugs which are essential like pilocarpine and needed like beta blockers suddenly go off the shelves, and they're just not available. Affordability, some of them, again, I'll come to that very shortly, where some of these drugs which are new and we are not in the gene therapy class yet. Just earlier today, I was reading about a drug which cost $2 million for treating a child who was 2 years old, one shot. So thankfully, our glaucoma drugs are not in the $2 million range, but they are still expensive. We need to choose a medication based on compliance. If I used to have loads of patients on COSOP twice a day, alpha-gan 3 times a day, prostaglandin at night, and put in a pilocarpine if things don't work. But sometimes I think as the hair grows, you tend to believe that you're fooling yourself by believing that the patient's actually putting in 10 drops a day. It doesn't happen. It might happen on half the time, 50% of the time. You might have a patient put all 3 drops religiously, but really, when you try to do it yourself, it's tough. The other choice of the drug also depends on the life expectancy of the patient as well. Again, alluding to the same point which Dr. Omnia was making in her talk. So I like to start with the most potent single drug and combination drugs when the target IOP is not achieved or when there's progression or damage. It's nice to use a drug with different mechanism of action. So a drug which improves outflow, like a prostaglandin analog, is very well combined with a beta blocker, which is actually reducing aqueous production. We see lack of response all the time. That's why we have so many medications running, so many medications available. And the reasons for lack of response could be something as simple as a non-responder. And that's something we never have an answer to, as to why one patient responds to one drug and probably the patient's brother or sister doesn't. A non-compliance, that's a standard one, where you'll have a patient putting in drops 2 days before coming to you, and then probably skip 5 or 6 days in between. I think with the popularity of preservative-free minims, yes, they're expensive, but they actually help compliance a lot. I use a fair bit of preservative-free drug, and because you are actually prescribing 60 minims for 60 days, I tell the patient up front that it is common for a patient not to miss medication, But the way you can make out that you're missing yourself is by seeing at the end of 60 days, if you still have drops, still have minims left with you, you've been missing medication, then that's really not good enough. That's not good for you. Improper installation of drugs. There are lovely videos on this. We can YouTube it with the bottle going in as a torpedo, as a dart, as hit and miss. And we've all been to conferences where we've had a laugh on the way these drops have been put. And at the same time, I have patients who are very sensitive about how they instill drugs. I've actually been to some of my patients back who moved from here to India. They called me across to their house, and they had set up this wonderful little mirror with a setup of drop where they actually look at the eye when they're putting in the eye drop, just to make sure they're instilling it right. So there are both sides of the coin. And of course, wrong diagnosis. Sometimes, we keep putting in medications to reduce the pressure, whereas while the trigger might be something like a topiramate or a drug-induced uveal effusion causing the glaucoma, and your drops are really not going to help there. So this is a common picture that we see with current medication. You have tolerability issues, usually because of the allergic effects of benzalkylum chloride. This sort of conjunctivitis is a type of eye, is a common condition, I guess, when we use prostaglandins, but it's also common with most of the. It could be linked to preservatives rather than the drug itself. Now, the benzalkylum chloride over time induces damage to the ocular surface, and that has an effect on the surgical outcomes as and when that patient needs surgery later on in life. And of course, the conjunctival hyperemia, which comes due to preservative toxicities. So the ocular surface disease, which comes with these medications, is multifactorial. It has symptoms very similar to dry eye, and working in the UAE, this probably is our bread and butter. The dry eye to us is probably what cataracts is to at least back home in India. So what I'm trying to get at is that we have a population where there is increased tendency for dry eyes, and the ocular surface can get further damaged by the benzalkylum chloride. So because of this, ocular surface disease may affect the daily living of the patient, and it may also affect the long-term filtration surgery. So what options do we have to go over this ocular surface disease? The obvious one is preservative-free drugs. We're lucky now that we've got a lot of preservative-free options that are being available to us. This is something I've been hoping for and screaming for the last 3-4 years, if not more. Where I've been having my hospital order these drugs from till they become available here on a special order basis, just because you have these bunch of patients who have preservative toxicity. So in preservative-free drugs, we have the proper preservative-free ones and the back-free ones. The other good thing that's come off in glaucoma medications recently is newer combinations. The brimonidine brinzolamide combination, the BBFC, is wonderful, because that's the one which is without beta blockers, and that actually helps a lot in management. Because if you have, I'll come to that again, but if you have a combination like brimo, brinzo, 2 or 3 times a day, and you combine with a prostaglandin beta blocker once at night, in 3 drops, you've got 4 drugs going in, and that's probably the best sort of pressure control you get with the least amount of preservatives and in lovely patient compliance. And the other exciting bit is the newer molecules. We don't have them here yet. Rho kinase inhibitors, a couple of them which started off in Japan, the nitazoxanide or Ropressa, and the even more interesting one, which is rocklatan, which is nitazoxanide and latanoprost once a day combination, as well as the NO2 donating latanoprost or latanoprost Bunod or Vyzulta, and the other options which we don't have yet, but which is on the anvil, are the newer drug delivery systems. So in back-free medication, we either have, instead of back, we have Purite or Softxea being used, and the pure preservative-free. And I usually make the case for preservative-free topical hypertensives. Now, we know that as compared to, there are greater numbers of conjunctival cells from patients using preserved anti-glaucoma medications expressing inflammatory markers. So what that means is that with preservatives, there is a higher expression of inflammation. These inflamed conjunctiva over time will induce a tendency to scar. And of course, while that inflammation is ongoing, there will be hyperemia. Whereas when you talk about preservative-free eye drops, the survey revealed fewer symptoms in patients with preservative-free medication as opposed to those on preserved medication. So these symptoms could be pain, discomfort, foreign body sensation, dry eyes, tearing, lid itching. And this was a fairly large study on close to 10,000 patients. Along with symptoms, there was also the signs of hyperemia and blepharitis, SPKs, follicle, fluorescent staining, and eczema were also lesser in this group of patients. So my go-to drug as a start is usually a prostaglandin analog these days. In most cases, more often than not, because they increase the uvascular outflow, they increase trabecular outflow facility. Because it's a once daily dosing, it improves compliance. We need to be careful in using and use it with caution in uveitic glaucoma. That it may exacerbate cystoid macular edema, but that's what I like to use. Now, the difference now in this year or last year really has been prostaglandins without preservatives. So all along we've been using a lot of tafloprost, which is similar in efficacy to latanoprost in eyes with raised IOP and normal tension. And the tolerability of this drug is actually excellent. When you use a lot of prostaglandins, you can tend to make out which one's going to come to you with more hyperemia and which one's not. So I like the drug from that perspective. Of course, now from the last again, towards the latter half of last year, we've had preservative-free latanoprost available, and the big advantage with this one is it doesn't require refrigeration. So latanoprost as a molecule is something which we have known from the 1997, 98 when it came out. So we have the longer studies with latanoprost and in terms of travel, in terms of transport, and it's cheaper than the others. So it's makes a lot of difference, but it's good to have something to choose from. In Europe, they have hematoprost preservative-free as well. We don't have it as yet locally, so I have no experience. But with both the other two, I've actually had fairly good experiences with both of them. Just a word about pregnancy, that the same class of these medications is used systemically to induce labor. So it is controversial whether these medications have enough, whether these topical drops have enough activity to cause any adverse effects. But latanoprost, travoprost, tafloprost are all prodrugs getting converted by enzymes in the cornea. While the dosage needed to stimulate an abortion would be 400 cc of an ocular formulation, and we normally have 3 to 5 in a bottle, we still need to remember that all prostaglandin analogs are category C. So latanoprost, travoprost, bimatoprost, tafloprost, all of them are category C when it comes to pregnant women. So we need to, in fact, even women of childbearing potential, we should have, we should keep that in mind, that when we're using these drops. The other preservative-free med, I'll be coming to the combination drops in a moment, but other preservative-free meds which is now available to us is the dorzolamide timolol fixed combination, the COSA-PF, which also goes a long way. This is one of the drugs which I've been using for a long time, even before it's become available, just because I've had patients with preservative toxicities. And the ones who appreciate this drug, they just buy it in stock and go. When they just come, these are patients who don't stay in the UAE, they would have their 6-month stock, 1-year stock. And in fact, I saw this patient last week, and I was telling him, yeah, now it's easily available. He said, yeah, I've got 1 year stock. I'm fine. So the take-home message there is that the patients who have preservative toxicity, and with the same drop, when you give them a preservative-free one, when they realize that the tolerability is so much better, they actually swear by it. And as long as a physician, as a doctor, as long as you have a drop which is keeping things stable and under control, then then the next thing you want to do is make sure the patient's also comfortable with it. So I love the fact that we have so many options on preservative-free meds now. The other favorite of mine these days is the Brinzo-Bremo combination. Favorite because it does not contain a beta blocker, and while they are both more or less acting in the same place, where Brinzo reduces the aqueous humor formation, and brimonidine also does the same, and probably can increase a little bit of uvascular outflow, but because of the combination drug, they may have lesser preservatives. And the thing with beta blockers is that because beta blockers are used in most of the combination drug, we know that they are contraindicated in patients, especially with COPD, asthma, heart failure, bradycardia, hypertension, and first-degree heart blocks and beyond. Despite that, they have studies which have shown that half the patients with glaucoma will have who will have contraindications to beta blockers are still using it. So having something which is without a beta blocker is great. It can be used twice a day or 3 times a day, and we need to be careful. We need to be watchful about the allergies which come in, usually due to the brimonidine part. But it's something which we live with as glaucoma specialists. Again, just a word about pregnancy. I was asked to talk about this by a few people before. So I made a point to put in this line that when it comes to CAIs in pregnancy, there have been no reports of any complications following topical CAI in pregnant women, but it is still a category C drug. Brinzolamide also is a category C drug, and while you may get away using a carbonic anhydrase inhibitor topically in pregnancy, you have to assess the risk benefit. And certainly I won't use these drugs in the first trimester of pregnancy. While on pregnancy, since we are talking about alpha agonist, so sympathomimetics, we have the non-selective ones, which is epinephrine and dipivefrin, which are category B, but we don't really use them for glaucoma these days because of the tachycardias and the arrhythmias and the adrenochrome deposits and allergies. Brimonidine, on the other hand, is the only one which is category B. So if there is one drug which is the safer amongst the others, it's probably brimonidine. But it should be discontinued in lactating mothers. So it can be something which can be used in pregnancy, but it's something which, with caution, with punctal occlusion, with discussing with the mother and the gynecologist. But certainly, once the mother is delivered, we need to discontinue brimonidine. So the newer molecules, that's where a lot of interest is coming up, because we just don't have enough drops, right? And we don't have the perfect surgery. You talk to a trap person, he's going to say, let's do a tube, but you talk to a tube person, they say, you know what, mix are better, and we can go on and on about that. So we need more drops, because end of the day, about 80% of your glaucoma management is going to happen in your outpatient, not in the OT. Rho kinase inhibitors or ROCK inhibitors is a buzzword nowadays. They target cells in the trabecular meshwork to increase the aqueous outflow by reducing the resistance. Rapasodil was the first one. The mean effect of reducing the pressure was 3.7 millimeters of mercury. It was not great. It came out in Japan earlier. Is available in India now, but what we're actually waiting for is Ropressa or Natazodil, which, in addition to reducing reduces the aqueous humor production. So it improves the outflow and reduces the production, which is where the IOP lowering is about 5.5 millimeters. And when combined with latanoprost, Rocklatan, which is a Natazodil latanoprost combo, holds a lot of promise. So it gives us a new class of drug to add on to our existing treatment. The biggest problem with these Rho kinase inhibitors is the hyperemia. It's about over 60% of patients will have hyperemia. There's this case for subconjunctival hemorrhages and cornea verticillata, which may not have any clinical significance, or at least we don't know much about it. Cost is a concern. These drugs would be anywhere in the range of $300. I don't know what it's going to be when it comes here, but yeah, that is going to be an issue. But yeah, it's not $2 million. So there we go. The other new drugs that we have are nitric oxide donating prostaglandin, so latanoprost commercially known as Vyzulta. It aims to combine the complementary mechanisms of PGF2 alpha and nitric oxide. So it enhances the level of nitric monoxide, whose release in the trabecular meshwork activates ion cells to provoke relaxation of smooth muscles. So the nitric oxide increases the trabecular outflow, whereas the PGF2 alpha increases uvascular outflow. So it's acting on the outflow mechanism, but on both trabecular as well as uvascular outflow. So that's the other drug which I'm eagerly waiting for to use as and when it comes. But again, it's a $300 drug, so we need to keep that in mind as well. The other thing people are talking about is drug delivery systems. This is a lot of talk that's been on about punctal plugs. Nothing much has really gone on. We keep seeing stories, and I guess we need to give it time and see how things pan out. There have been latanoprost and bematoprost tried in punctal plugs as delivery system, but an idea is to get a product that will deliver drug levels for 3 months or longer with excellent retention of plugs, which is actually very variable. The other way of drug delivery could be polymer microspheres. These are sustained release. Timolol has been tried. These are small microspheres where you can have a subconjunctival injection in normotensive rabbits, and it's been shown to reduce IOP over controls. But again, this is more in research stages, not yet clinical. Bematoprost ring, again, is something which was spoken about a lot with an efficacy of about 6 months or so. There are multiple sizes, but no first-hand experience with these as well. Now, the other problem that we have in our part of the world is drugs losing popularity due to them not being available. There's nothing wrong with beta blockers. Yes, of course, there are this huge group of patients where we can't use them, but it is a drug which is 30% efficacious. It's not fashionable, it's not fancy, it's not hi-fi to use the simple old timolol over the fancy, ROCK inhibitors that you have now. But you know what? They work. It's just that I haven't seen timolol eye drops, at least the non-generic ones. Thankfully, I think in the last 1 or 2 months, the generic ones have become available. Betoxolol was available on and off, but it's less effective in comparison. Just a word about beta blockers, that they're also category C. So I do as systemic beta blockers. Topical beta blocker data is less, but again, it's something which I don't use in the first trimester. The other drug which we are not getting these days, and I hope we can do something about it, is myotics. I don't know how to manage pilocarpine without I know how to manage ACG without that pilocarpine, and every time when I have to do something as simple as a PI or even a trab, the last couple of trabs which I did were both with uveitis, so thank God I didn't have to use pilocarpine. But the next one that comes up, it's going to be fun because it's just not available. So for some drug which has been around from 1887, we could have a little bit here. I wish we can do something about that. So just like tropicamide, which has become so hard to get in our day-to-day practice, pilocarpine on the other hand is having the same fate. So I hope we can do something about this. But yeah, that's what I had to speak about today. Thank you all for your attention. I'm sorry my slides kept going up. I think I've done something about my timer, and which is what messed it up, but sorry about that. But thank you. So I think in the interest of time, it's probably going to be better if I just let Dr. Ankita finish her talk, and then we could go ahead with the discussion.
Yes, we have a lot of questions, I think, so at the end we can do them.
Perfect. Yeah, I'll do that. I'll try to answer some questions while I'm at it. And if Dr. Ankita, it's a pleasure and honor to welcome you. If you could start your slide sharing, please. Thank you.
Thank you, Dr. Prashant, for the introduction, and it's a pleasure working with you. And thank you both, Dr. Omnia and Dr. Prashant, to give me this opportunity to speak here. So I'll be talking on lasers in glaucoma management. So the objectives of my talk will be a brief description about the principles of laser, then talking about the important lasers in glaucoma practice, including the SLT and micropulse transscleral CPC, followed by a slide on management of post-laser elevation of IOP. There's no financial disclosure. So in terms of basic principles, we all know laser stands for light amplification by stimulated emission of radiation, where all the photons are emitted and they are in phase and coherent. So we have lasers which are either continuous or a pulsed laser. The terms are self-explanatory. The Q-switched laser means there is a giant pulse output where whole of the energy is concentrated in a very short duration, which is in nanoseconds. So it's kind of piercing or kind of cutting laser. So the ND-YAG laser that we use for PI, that is iridotomies, is the Q-switched laser, which works by the principle of photo disruption, where a shock wave is generated and it kind of disrupts the tissue. The continuous wave laser is the argon laser that we use in iridoplasty, and as well as some use it in PIs. So when it is used in lower energies, it works by photocoagulation, where it coagulates and mainly causes contraction. But at higher energies and shorter durations, it works by photovaporization, where it converts the plasma into vapors and it kinds of penetrating. Again, a shock wave is generated. So I'll start with lasers in narrow or closed angles. So the most important is the peripheral iridotomy, which is the most commonly used. Iridoplasty is less commonly used because of its short lasting effects and none of the studies proving its long-term efficacy. So iridotomy is mainly done by ND-YAG, Q-switched ND-YAG laser. Argon some, but it mainly helps in the sequential laser where patient is on an anticoagulant where you don't want to bleed by ND-YAG laser, or in the of iridotomy is pupillary block. So it has to be there. It can be primary or secondary when you have an aphakic or pseudophakic pupillary blocks. So plateau iris, again, here the indication is to relieve the pupillary block. A PI won't be helpful in a zipped closed angle due to neovascularization or where you have other mechanisms, the secondary mechanisms of angle closure, some push from behind, uveal effusion, drug induced. And it can also be used as a prophylaxis in cases of pigment dispersion where there is a posterior bowing of iris and you see some irido-zonular lenticular contact. So pre-laser, you need to do gonioscopy, which is very important, IOP, undilated disc. Counseling here is very important because you need to explain the complications or side effects, which are obviously self-limiting and very minimal, but still the patient should know, and you need to counsel them that they may need to come again. They may need second for the laser. There might be some blurring or some visual discomfort. So topical pilocarpine is constrict the pupil and assist in doing the PI, and we do give prophylactic anti-glaucoma medications to control that IOP spike. We use Abraham iridotomy lens. It helps in concentrating the power over lens. It stabilizes the eye and it magnifies the area, so makes it easy to do a laser. You need a coupling fluid or gel along with that. So in the technique, so we start by selecting the location. So what I usually do is I avoid a location where it is bisected by the tear film or where your lid is lying. So either it should be completely covered by lid or completely exposed. So I have seen visual discomforts even in completely covered PIs, but still that is how you start. And in cases of acute angle closure attack, you can just do it anywhere. You need to abort the attack or the iris bombe whenever the cornea clears and you can go ahead and do a PI. Mostly it is done with ND-YAG laser. So energy varies depending on the tissue response or the iris you are treating. Usually it's a single pulse per burst. Maximum energy in one sitting, you should try to limit it to 1.2, in fact lesser than that. And in case you cannot penetrate in one sitting, you can always go ahead, wait for some time if there's lots of pigments or there's a bleed, and select another site or another time to do the laser again. I usually prefer a slight posterior defocus, where I focus the laser crisply at one point and then move the slit lamp a little forward so that it's slightly posteriorly defocused, so that the burst that happens, it happens in the iris stroma. It's usually done through the center of that Abraham lens, and try to be perpendicular to it for the best shot. Ideal size would be around 150 to 200 microns so that it doesn't close later. So post laser, we give some steroids or NSAIDs for a few days to prevent the inflammation from flaring up. IOP is checked 1 to 2 hours post laser to again see that IOP spike, and follow up after 1 week and 1 month, and later as and when required based on individual patients. So this is, PI is the first step, it's not the last. So even if you're doing it in a suspect or someone with early stages, even the angle opens up, you need to keep doing sequential gonioscopy, as Dr. Omnia mentioned. So after 1 month, we do assess patency, we do a dilated gonio IOP and a disc evaluation to rule out plateau iris. So what can be the complications? So most of the complications are transient and self-resolving. You see a hyphema, you press on the lens, it usually stops there and then. You see AC inflammation easily taken care of by steroids and anti-inflammatories. The IOP spike again can be dealt with the anti-glaucoma medications. And the corneal injury, usually you don't see it unless there is a very shallow AC or higher energies are used or it's slightly defocused. Lenticular opacities, again, they are more common with argon laser, and they're very localized and don't progress. The diplopia, glare, or dysphotopsia, though it's seen less commonly or rarely, but it's real, and it's usually seen when the PI is bisected by the tear meniscus because of the prismatic effect. So in occludable angles or the primary angle closure suspects, when should you go about and do a PI? So these cases can be very easily observed and followed up, especially because they don't have any signs that the angle, anytime there's any irido corneal contract. What will be the indications? If there is any strong family history, if the patient is one-eyed, patient is symptomatic, the patient has some retinal problem which leads repeated dilatation or some intravitreal injection, or when you explain it to the patient and the patient actually wants it, or the patient cannot come for a follow-up. Why? Because most of the studies have shown that the risk of angle closure attack in a PACS is very low, 1 to 6%. So it's very low. It's not so high that you treat all the patients of PACS with a PI. Even after dilatation, the risk of angle closure is pretty low. If you see the different studies, 0.64%, 1.3%, which is very low. So you don't need to go ahead and do PI in all the angle closure. You don't need to treat 100 patients to prevent that 3 patients or 1 patient from landing into angle closure attack. So the key points that it mainly treats the pupillary block. So you need to see that it is there. All occludable angles don't need a PI. You can easily observe and follow them up. Long-term follow-up is very important. Serial gonioscopy should always be done. And disc and field evaluation continues, even if the angle opens and the IOP is normal. We go ahead to laser peripheral iridoplasty. So here the burns are applied to the extreme periphery of the iris to contract it and pull it away from the angle. Mainly argon laser is used. So not many studies have proven its efficacy or role, and it's mostly short lasting. So I don't think it's very commonly used in clinical practice. The indications would be plateau iris configuration and syndrome for any residual angle closure and recent pass, mainly appositional closure or pass which you see are forming as you observe and follow up the patients. Acute angle closure attack when LPI or is not possible and medications are not able to resolve that attack, it's easier to do a iridoplasty because it doesn't need that clear focus, and it sometimes may abort acute angle closure attack as per studies. So the technique, again, after patient counseling and consent, you go ahead and constrict the pupil with pilocarpine, topical anesthesia, and an AGM for blunting that IOP spike. You insert the same Abraham iridoctomy lens and with a coupling agent. So settings, again, they vary with the type of iris you are dealing with. but mostly you can start with a large size, 300, 500 microns, lower energies. So, and long duration, because you want that iris contraction. You don't want a penetration or a disruption of the tissue. You just want a contraction so that the iris is pulled from the ankle. So you need to treat as much to the periphery as possible. So because you need the effect in the angle. So the laser spots need to be separated by 1 to 2 laser spot size, approximately 4 to 6 per quadrant. So post laser, again, you measure the IOP 1 to 2 hours to see for the spike. Topical steroids are needed for a few days. You follow up again at 1 week, 1 month, and as and when individual case requires. The long-term follow-up is again patient-based. So the complications are again minor and self-resolving. You may have an IOP spike, you may have iritis or a focal iris atrophy, easily controlled by steroids or NSAIDs. You may have a corneal burn because of the energy is defocused or extra energy is used, or the angles may not open, they stay closed because the synechia are old. Then we go ahead to laser trabeculoplasty. Conventionally, it was done using argon laser, but nowadays it's the selective laser trabeculoplasty, which is done using 532 nanometers Q switched frequency doubled Nd:YAG laser. The most important point here is the very short pulse duration, which is just 3 nanoseconds, which is shorter than the thermal relaxation time of melanin. What does that mean is that it's so short that melanin, by the time it relaxes and it releases the energy, it's a long time, after the laser is already over, and then energy slowly released. So it doesn't damage the tissue, it only heats it up. So that's why the energy and the temperature rise is concentrated to the pigment granules, and there is hardly any collateral damage. So the mechanism of action, nobody knows for sure, but there are various theories. The mechanical effect, it's more in favor of ALT, because in SLT, we don't see that much of a coagulation or contraction. But still there is some contraction with tightening of the trabecular ring and widening of the adjacent pores and opening of the Schlemm's canal. More in favor of SLT goes are the cellular and biochemical mechanisms, which show that it induces the cell division in trabecular beams, and it somehow remodels the extracellular matrix and reduces the outflow obstruction. Also the biological response in terms of release of cytokines and various inflammatory mediators, which signal the macrophages, which clear up the debris from the trabecular meshwork. Basically, the patient's own body is stimulated to work in clearing up the trabecular meshwork. So what are the indications? Basically, if an angle is open and you can see the PTM, you can just go ahead and do a SLT. Even in narrow angles where you have done a PI iridoplasty, you can see the PTM, you can go ahead and try an SLT, because it's mainly stimulating the trabecule. You don't see any damage and it is very well repeatable. So you can just go ahead and do it. In pigmentary and pseudo-exfoliation glaucoma also, studies have proven its role. It's really effective. In fact, I have tried it even in failed filtration surgeries, where you, before going to next surgery, you can just go ahead and try a SLT too. The success rate is less, but still it's worth a try. Even in pseudophakic, aphakic glaucomas, even NPGs, because it blunts the IOP fluctuation, which is very important. Efficacy is as much like prostaglandin analog. Where you can't do it is mainly uveitic glaucomas, because it causes inflammation, or where the trabecular function won't improve, like in developmental. I tried it in developmental 18 years, 20, it didn't work in my hands, but there are case reports that it does work. And then, in angle recession glaucomas, where, you are not going to improve the trabecular function, there it won't work. And so so SLT versus ALT, so it's mainly a gentler laser, because there's hardly any histologic scarring or coagulative damage because of its time, which is very short duration pulse laser. So that's why you hardly see any histologic or collateral damage. Also, if you see the spot size, it's more, it's a larger laser, so it doesn't need that precise focusing that you need with ALT onto the PTM. So it's a kind of diffuse focus. You focus it on PTM, but then it's there over the angle. And so it's easier to perform basically. So pre-laser, you again need to do careful gonioscopy, pilocarpine to constrict the pupil, topical anesthesia, and a gonio lens. So in the treatment, you basically aim it on the PTM. It's large, obviously it's over the whole angle, but then you focus it on the PTM. You need some 110 shots, 360 degree. The spot size is fixed, it's 400 microns. You can vary the energy. It's like 0.3, 0.4 to 1.2. You basically start with 0.7, 0.8, and basically you need to monitor the bubble formation. You don't need that bubble formation on every shot. If you see, suppose you see it every 2-3 shots, it's good enough, and you need to keep changing your energies over 360 degrees. It's not like with same energy you're going to complete your treatment based on the pigmentation and amounts of bubble generated. The bubble should not come into the anterior chamber. They should stay there in the angle. If you're seeing bubbles after every shot, then reduce the energy by 0.1 and see again. Similarly, for 2-3 shots, 4 shots, you didn't see any bubbles, try to increase the energy by 0.1. So you keep changing the energy and you treat that 360 degrees. So during treatment, usually there is no observable tissue reaction. Post laser, you give an anti-glaucoma to blunt that peak. You check the IOP again after 1 to 2 hours to see IOP spike. And you need to give these steroids or anti-inflammatory eye drops for 4 to 7 days. So there was some debate that the main mechanism of action theories are that it's the biological response or the anti-inflammatory response that leads to its efficacy or IOP reduction. Then why do we need to give steroids? But there's the SALT trial, which has kind of shown us that giving these steroids and anti-inflammatories, in fact, helps and reduces the pressure later. So adverse events, mainly these IOP spikes that we get, which are more commonly seen, more pigmented IOPs when you're using more energy, but they can be seen like after any case, less common, but still you may find it there. Iritis, again, there may be transient iritis, which resolves on its own with NSAIDs and steroids for a few days. There are few case reports of hyphema, which are transient and resolve on their own. In high-risk cases like diabetic macular edema, pseudophakic CME, you may see a macular edema as well. There are case reports of reactivation of latent herpes simplex virus, and some case reports on corneal haze and decompensation. So there have been studies where they studied the corneal endothelial cells post-SLT. So all the changes were very transient, and long-term, 1 week, 1 month, there was hardly any long-term change or reduction in endothelial cell count. Now we go ahead to cytophotocoagulation. The main mechanism of action is here with the conventional transscleral continuous wave CPC was ciliary body ablation. There was mainly tissue disruption, which reduced the aqueous production and increased the uveoscleral outflow. So it was still reserved for advanced and refractory glaucomas, even though it was easy to perform and kind of very non-invasive, but still it was done in those cases with very low vision potential because of the unpredictable effects, limited success, and complications like phthisis, loss of vision, inflammation, RD, and vitreous hemorrhage. So now recently, there's this new laser which has come up and being researched and used a lot, micropulse transscleral laser therapy, which targets mainly the melanin in the ciliary body, and it therefore reduces the aqueous production by the same mechanism as the conventional by targeting the ciliary body, and it increases the uveoscleral outflow without actually photocoagulating the target, and also shortens the ciliary longitudinal muscles, opening up the Schlemm's canal and trabecular meshwork. But the important point here is it's in pulses. The energy is given in pulses, where on time is much less than the off time. So the tissue gets the period to rest. So the heating or the heat damage is not that pronounced. There's hardly any collateral damage seen in various studies and histological examinations. There is hardly any disruption of ciliary body, only a tissue remodeling. So that's why it's very non-invasive, easy to perform, and hardly any complication like phthisis or vision loss reported till now. Duty cycle is 31.33%. So main indications, initially we were doing CPC only for refractory glaucoma, so that's how we started. But the indications for this micropulse are expanding. Lots of research going on. We see lots of literature, case reports, and studies coming up where it's done in all types of glaucoma, especially during these COVID times, even performed in seeing eyes, and till now nobody has reported any vision loss or phthisis bulbi. So technique and adequate anesthesia in this case is required because it's painful. So you need to give some peribulbar anesthesia, some sedation. You can use a speculum to retract the lids, or even you can retract it with your fingers. A coupling agent is needed here because for proper energy distribution. And the probe here is moved in a painting manner along the two semicircular areas below and above sparing the 3 and 9 o'clock positions. The probe is passed back and forth multiple times. The probe is kept perpendicular to the sclera throughout the treatment and moved with gentle constant pressure, maintaining the float plate against the conjunctiva. So there have been a few revisions in the probe design. The latest revised probe 2, it uses around 2500 milliwatt power and 10 seconds per pass, so total 50 seconds per hemisphere of treatment. Again, this keeps varying depending on how much pressure reduction you need, how refracted the glaucoma is. But this is the recommendation from the company with which to start. So this is how you go about painting in the inferior and the superior hemisphere with gentle pressure and sparing the 3 and 9 o'clock position. And the probe design is such that you keep these bunny ear areas towards the limbus, and it targets the ciliary body around 3 mm posterior to the limbus. So post laser, again, you give steroid drops, which are tapered. So here the inflammation after this micropulse is not as much as you see with conventional CPC. So steroids may be tapered earlier. Cycloplegia is optional. A depot of subconjunctival steroid may be given at the end of the procedure. You have to continue the anti-glaucoma medications pre-op and post-op till you start seeing the IOP drop. Follow-up is done at next day, 1 week, 4 to 6 weeks. IOP reduces over 1 to 3 months and it can be repeated. So lots of studies have done which show it's safe. There's minimal cases, 1 or 2 cases of hypotony which resolved on their own, no case of phthisis bulbi till now. And it is quite efficacious, showing 40, 30%, 50% reductions in IOP, even used in refractory pediatric glaucomas with good results. So the complications are again self-limiting and resolving, like pain, IOP spike, inflammation, and hypotony, which resolved on its own. So the last I would be talking about management, because in all these slides we saw all lasers lead to this post laser IOP spike. The reasons are not sure, maybe because of pigment release, maybe because of the laser bubbles, maybe because of inflammatory mediators, maybe because of the hyphema. But any laser can have a IOP elevation. So we have to be very careful when we are treating some advanced cases, or where we don't want the IOP to spike very high. So we do give prophylactic anti-glaucoma pre and post laser. We measure the IOP 1 to 2 hours. In high risk eye, you can measure it 3 to 4 hours later. Why? Because 96% peaks are seen within this time. So it is, you tend to detect all of those, maximum of those, if you do measure the IOP later. If there is more than 5 mm above baseline, you can recheck it again. And if it's clinically unacceptable, going very high, you can add an anti-glaucoma above whatever the patient was taking. You have to ask the patient to continue his AGM if they are on AGMs before the laser. So they have to use it before laser and continue the routine till you see the IOP drop. You can give oral acetazolamide or IV mannitol may be needed if the levels go unacceptable and you know it's an advanced case or won't be able to tolerate that pressure rise. And you have to closely monitor till the IOP return. You may have to see the patient again instead of directly at 1 week. And sometimes you may need to counsel the patient if you're giving them a trial of the laser before going to the incisional surgery, that they may have an IOP spike which might need a incisional surgery. To conclude, lasers do have a definite role in glaucoma management, because sometimes we don't see the compliance, don't see the lots of side effects of eye drops. So they bridge that gap between medications and that incisional surgery. Being less invasive, they have a better safety profile. But obviously, detailed counseling is very important, and complications must be kept in mind. Thank you.
Wonderful talk, Dr. Ankita. Thank you very much. So we've had a whole load of questions coming in. So I think let's unmute all of us, Dr. Ankita, Dr. Omnia. One of the questions, since we just spoke about the lasers, let's just start with Dr. Ankita itself. There was a question which came in just now, which was, what's the location of the iridotomy that you prefer? Do you prefer interpalpebral or do you prefer it to be hidden by the eyelid?
So I do prefer it to be hidden by the eyelid, but sometimes I check the position. Sometimes the upper eyelid position is little high. So in those cases, I go for other locations, mainly temporal or inferior, but I try to avoid the lid margin. But yes, if I find a nice script at
What about you, Dr. Omnia? What do? Do you actually aim or aim for 3 o'clock, 9 o'clock, or avoid that? Or?
Actually, to cover my peripheral iridotomy, so but I avoid the lid margin always.
Okay.
Yes.
Right.
Either covered or a little bit down. As
so I think the important take-home message is avoiding the lid margin. I like to do the laser where I get the best script, frankly. In fact, we've had this discussion a lot on the location incidence of photopsias and dysphotopsias when the laser is done under the lid margin, because the tear film which causes a diffraction of the light and causes a dysphotopsia. Whereas if you're actually doing an inferior one, the eyelid effect doesn't come in when so if you're doing a laser iridotomy at 6 o'clock, it actually doesn't cause any symptom. That said, what I'm doing, I'm at 1 o'clock or 2 o'clock, just away from the lid margin. If I'm keeping it under the lid margin, I just make sure I'm as high as I can be, say 12:30 on one side or about 1:30 on the other side. So that's what I'm doing. But I think you asked 10 glaucoma specialists this question, you will probably get 9 answers. Okay, there was another question while on lasers as to when is it okay to consider SLT as a first-line therapy?
So basically, SLT can be considered as a first line in any ocular hypertensive whom you are about to treat. You know, those high pressures. In fact, if you do SLT on treatment naive eyes, it's been proven that the effect is much more. Early to moderate glaucomas, where you know even an IOP spike, it's not going to harm the patient. But I usually avoid it in advanced glaucoma. During my fellowship training in Switzerland, there the patients, they do agree for SLT as a first line, but when I gave the same option in India, they didn't. So I did SLT when the drops were not. You can offer them in open angle glaucomas, early to moderate, and ocular hypertensives. But yes, to avoid it in advanced, I would say I would avoid it in advanced glaucomas at a first line treatment.
But you, Dr. Omnia, what do you do? I think we've lost Dr. Omnia.
The treatment, the SLT?
Yes.
Yeah, no, I'm here, but there is network problems, so the voice is... Yeah, the SLT really not tolerating. So first, the patient who's not tolerating medication, and the ocular hypertension, most probably, I can start with SLT, but I have to observe them as well. This one thing, and sometimes when I want to add another molecule, the patient on monotherapy for a long time and he's okay, and the pressure now start to just go up before adding any treatment. This is not first line, but I can consider it as one drop. So I'm considering the SLT as drop. So I use it for such patients. And it's happened to me that the pressures really come down. And I remember one of my ocular hypertension patients, and I stopped the medication and she was on just all SLT after SLT.
Yeah, same here.
So in my work, I think in these days with Corona, etc., I actually don't mind SLTs as long as the patient understands that at the end of the day, the worst thing that can happen is it's not going to work. That is if I have a patient with an early glaucoma. Yeah. On the other hand, if I have a patient with an advanced glaucoma, like both of you said, I'm a little more wary about the spikes. If I have a patient with an advanced glaucoma who I'm taking up for surgery and have nothing to lose, and he understands that, listen, we'll do this, but if you get a spike, you're going into the OT, I don't mind giving it a shot just because I don't want to unnecessarily get a patient into the OT.
I saw some questions as well. I don't know if Dr. Ankita also she wants to answer. There is one question here. What's the role of SLT in end-stage glaucoma management, especially when the patient is afraid of wipe-out syndrome and has poor complex medical therapy? This is one of the questions. You can answer it.
Yeah, so actually I have tried it, but because of the fear of IOP spike, what I did was I did 180-degree at one sitting, and 1 week later I did the next 180-degree. I didn't do the 360-degree in one go, just to check for the IOP spike, and one eye at a time. So I have done that, and in some patients it does bring down the IOP, where the patient is on medication, they don't want a surgery, and the pressures, advanced glaucoma pressure is say 22, 24 on maximum medications. I've tried it, and I've seen the pressures coming down to 14, 16. But again, there were patients in whom it didn't work. So obviously I counsel the patient beforehand that there can be an IOP spike. We may still have to take you up for incisional surgery, but yes, in some patients I have seen response and have go ahead and done it. So it does work. It does work. When you see the PTM, even after one incisional surgery also there, even with the Ahmed valve, if you see the PTM, you can still go ahead and take a trial of SLT. But with counseling, that it may not have the same results as you see in treatment naive eyes.
And one more question about the SLT, so at least we finished the laser. Has the SLT effect in Caucasian as our patients?
No, so yeah, so basically, see, the difference is, I in my fellowship, I've seen it being performed in Caucasian eyes. I've seen really good responses, and even with repeat SLTs, they were like quite stable for 1 to 2 years. SLTs were repeated, again, a good response. But in my practice, first the patients would not agree for a primary treatment, and when I did go ahead, the drop was not, because patients were already, whosoever agreed for SLT were already on maximum medication, or they were non-compliant to medications, or they didn't want to use. So I didn't see the result as good as it. So I don't know, it's because of the factors that we do it later in the course of the disease, or we are not treating the treatment naive eyes, or it's because of the genetic makeup of the trabecular meshwork or the eyes. So I think we randomized trial.
I
got disconnected.
Yeah, I observed something between the Caucasian and French population or European population. They accept the laser easily. Population, and I think so. It will give the same effect, maybe also in our patients as darker trabeculum, so might absorb more energy.
Because I've seen good IOP reductions post SLT, yes. If they agree. But the thing is, they don't agree for it as a primary. There, the patients would agree. If you offer them the treatment, they don't have to put drops, so many drops, and even starting the drops, they would easily agree with SLT, especially because there are hardly any complications and it's an OPD-based procedure. So yeah, so maybe it's more about.
Yeah, actually, today we want to just send the message, or to address the message to our colleagues that, and we have to keep thinking about, because we have this tool, which can give good results.
There was a question from Dr. Mohini. It says in glaucoma practice, in the present COVID-19 scenario, are you still checking, has it affected glaucoma practice, especially measuring pressure with the applanation tonometry? I think I would like to touch that. So it has been actually discussed that applanation, because the way to clean the applanation, with whether you're using sodium hypochlorite or whether you're using alcohol swabs, both ways are effective in COVID-19, as opposed to doing a non-contact tonometry where you actually have an aerosol spread when you're putting in a puff of air. And that aerosol, if the patient is COVID positive, technically the tear film which can stay on the, technically the tears which spread when you're doing a puff of air can actually affect the next patient. Unless we are using an eye care which is disposable for each and every patient, then that's pretty good too. But as such, the consensus has been that using applanation in COVID-19 is actually fine. But this is my impression. But Dr. Omnia or Dr. Ankita, is there anything different that you're looking at?
Thank you to answer this question. Because me myself, even I was worried about it.
Right. No, because I thought it was very relevant to them.
So I know the idea. So I work with him, so I know the idea. So I've been using.
Dr. Omnia, there was a question again about the visual fields, about how often do you want the visual fields to be done? And
yeah, according to the guidelines.
You mentioned it, but if you can just reinforce that, please.
Yes, according to the guideline, for the first 2 years, we need to repeat the visual field 2 to 3 times in the first 2 years, because still we don't know the patients. And most of the patients, the first visual field will not be reliable, so we need to repeat it maybe more to our diagnosis. If we have he is ocular hypertension, 4 times visual field every 4 months for the patient who has advanced glaucoma.
There was a question from Dr. Mahmoud Al-Rubi. He said that what would be the highest range of IOP that could be best treated by the SLT?
So
do you keep any limit in your head?
So I have treated 40 pressure. Obviously, I started AGMs 40. Yeah, so I started AGMs obviously, and the pressure did come down to. So I started AGMs, and then 1 week later I did the SLT. But so it was a developmental 20-year-old with presenting with these IOPs. I gave a trial of SLT. It didn't work. So, but there was no IOP spike further. Obviously, with AGMs, the pressure was in 30, 30s and late 20s. So yes, so 40 is the highest I have treated. Apart from that, obviously, as I told you, none of those primary glaucomas which I diagnosed, okay, now do you want SLT? Nobody agreed in India. So I mainly treated those on maximum medications or intolerant to medications. So IOP used to be around late 20s, 30s. So 40 is the highest that I have tried.
Another question which said, what IOP level should patients with ocular hypertension without any, should you treat these ocular hypertensives, those who have no changes in disc and field, what IOP levels do you actually treat these patients? Right? To me, in my head, I don't have any number. I guess when the pressure goes above a 28, I treat. I'm not sort of, but below 28, if I have a patient with no family history, with a thick cornea, with someone who I know is going to follow up, who I know is not going to be lost to follow up, then I don't mind. Watching that patient and follow. And also it depends on the patient psyche. The patient needs to understand that when we are not treating a patient with ocular hypertension, you are essentially waiting for damage to happen. My understanding of the old study was a little different. My understanding was that out of 100 patients, 9 patients would develop glaucoma. Now, if you treat them, instead of 9, 4.5 would develop glaucoma. So you reduce the risk by about 50%. Now, the number needed to treat it is about 20, which means that you need to treat 20 patients to help one patient. So I don't think it's fair to put 20 patients on medications. If you have an SLT which works well, it's different. But and to answer the question about what IOP level, it will vary from patient to patient. About 28, it's a definite cinch that I would treat. Below that, it would vary from person to person. Dr. Omnia, do you approach it differently?
Yes, Dr. Prashant. Sorry, I lost the connection. I wasn't with you.
Oh, sorry. No, it was about what's the highest range of IOP that you would, what level of IOP you treat your ocular hypertensives? Like, is there any number in your head that you say beyond a certain level, even if you're ocular hypertensive, I will treat you?
Maybe I'll go to 30, but I'll try to the maximum to lower the pressure as maximum as I can, actually, before starting the SLT, of course.
Yeah. No. So what the question is that so till what level will you leave the pressure untreated? If the pressure is 24, disc are fine. Are you okay? If it's 26, are you okay? If it's 28, are you okay? And I think this number is varying from person to person.
Yes, it depends to all risk factors. I have to study the whole scenario. but I don't think so. I will keep him above 30 without treatment.
Yeah, because again, the risks at 30, the risks are different. So risk of hemorrhage is, yeah.
Yeah, 27, I will treat. 28, I will treat.
So another question just came up was, in a patient with on anti-glaucoma medication, when should you stop treatment after SLT?
So again,
when do you stop the treatment? When do you stop the drops? Once you've done an SLT, how much do you wait?
So I would see the response, the IOP response. I don't stop it immediately, especially because if you're doing it to bring the pressures down where the pressures are high, even with all the medications, I see for the response. I see how the patient, the IOP is coming down, and see what is the target IOP for that patient. So you have to take the patient as a whole. So if the usually 1 week, I just continue the patient reviews in 1 week. If I see the pressure is coming down, sometimes you see the pressure drop within the first week. So then I would reduce one molecule at a time. I won't suddenly reduce all the treatment. So if I see the response, I'll start reducing maybe at 1 week if I see a good response. If not, then I'll again review in 1 month and then gradually bring the treatment down, depending on how many molecules the patient is on.
Right.
I think we need to remember always that the management of glaucoma patients is so customized. Yeah. It's a puzzle. You have to study everything.
So it's very individualized, varies from patient to patient and everything.
So Dr. Rajiv Juchi has this question about the role of the star glaucoma predictor, which was made a few years ago by Pfizer. I used to have the star and the star 2, both the calculators sitting on my desk for the longest of time. And then ultimately some of my notes actually had this number written, that this is when I was trying to justify to myself as to what that risk factor, if I'm starting a patient on treatment or not starting a patient on treatment. If I had, if I wanted to give myself a number, I was doing this. And then there was an online star calculator also, which had come up. But I think at least since the last 5 odd years, personally have not used that, because it goes, I think in a way it goes a little bit on instinct, and for me it goes more on which patient I choose to treat as an ocular hypertensive. It's more on my assessment of the patient itself, that am I comfortable with this patient in leaving this patient with slightly high pressures. Am I sure that he's going to follow up with me? Is he a high risk or is he not a high risk? So that predictor model is effectively working in my head at the background anyway. So, but I'm not putting a number anymore. Yeah, it would be nice to hear from Rajiv what he does, because he sees loads of glaucoma too. What about you, Ankita? Do you use these predictors?
I don't use the predictors. Again, it varies from patient to patient. I'll decide based on all the risk factors and, looking at the disc, looking at the profile, and, what are the other risk factors associated?
The predictor takes that into account, right? The predictor looks at the risks. It actually takes in all the risk factors. Only thing I'm not comfortable about the predictor that you're using for a Caucasian population. Is it applicable to an Indian population? Is that application to a Southeast Asian population? I don't think so. But the predictor does not look at the mental psyche of the patient. So that's why that is my issue with the predictors, that we can't put everybody into one box and package them off.
Exactly as what you said, Dr. Prashant, about the fundus photo. If this applicable on the OCT as well, it will be changed in the future, and exactly for all those informatic calculators, it will be changed, and there are many, and even the patient will change his doctor. So you cannot depend really on this only. You have to take the patient, the whole story.
Okay. So I think we've addressed most of the questions. A lot of them were about SLT, which is so interesting, and fields. And I think one question Dr. Kubra had was, do you ask your patients about systemic hypertension and medications when you prescribe your topical beta blockers? Hand on heart. Do you ask your patient about, do you understand what they are? I ask and I write it down. But does it really make a difference to the beta blocker that you are prescribing?
It's more interesting in normal tension glaucoma. Okay. When I don't know actually the vascular side and the perfusion of the optic disc. So for me, it's much more important in such patients. If they have lower ocular blood pressure during the night. So, but even I ask everyone, but if it will change something, yes, it will change in advanced glaucoma as well, who progress, or the patient who progress, and my ocular pressure is always okay, but still they progress.
That's probably more, for me, that's a more realistic one. The ones who are progressing despite having good pressure control, then I start to explore out. Otherwise, it's a routine thing where I've written what the antihypertensive is. But when I've given my glaucoma meds, I'm probably not thinking so much about it. It's only when things don't go as the way they should, then I probably look more into it. One thing about normal tension glaucoma, I do tend to look at sleep apnea. That's one of my favorites, and at some point I think that's very important to look for sleep apnea in normal tension glaucomas, or in glaucomas which are progressing, especially your slightly, patient who's complaining about feeling a little drowsy, who's slightly obese, who's actually a little sleepy in your clinic itself, or there's a sort of a little way, a little manner of talking, and then they'll tell you, yeah, once in a while, I stop my car at a petrol pump and sleep off. Or if I'm sitting in a meeting, if I'm in a Zoom meeting like this and I'm off like in a moment, and my boss tells me, why are you sleeping? So those kind of patients, when you actually, it's worthwhile sending them to your pulmonologist for a sleep study, etc. And then do sleep management, do CPAP, etc., whatever is needed, treat the sleep apnea. That actually helps management of glaucoma.
I saw some patients who improved even their visual field even. One of them, his visual field is improved, and they are doing well, not progressing. But the main problem was the sleep apnea.
The sleep during the field test.
Yeah.
It's actually a very comfortable experience when you do a field test. So you can actually sleep off.
During the sleep test, you have the typical peripheral defect, and just because they were active when the test started and then they dozed off.
Yeah. And of course, like Dr. Rajiv just pointed out, the look for nocturnal hypotension. But again, that's the other thing in normal tension glaucomas. You keep sending these patients to the cardiologist, look for nocturnal hypotension, and he says, you know what, it was actually hyper. So it's not hypo, but I'm going to treat the hypertension anyway. So most of, over the years that I've been looking for nocturnal hypotension, I think the few positives that I've got from those 24-hour monitoring has actually been hypertension rather than hypo. Because even from a cardiac point of view, their definitions of that nocturnal hypotension is very vague. And even if you use the numbers that we have, trying to convince, and even if you come up to this nocturnal hypotension as a diagnosis, what do? You tell them to have a glass of tomato, juice at night just to bump up the pressure. That's what some people talk about off the record, but yeah. So I think we've had a wonderful discussion. I think if it's okay with everybody, it's time to go back to our families and have some dinner. Thank you so much, Inish, first of all, to the Emirates Society of Ophthalmology for putting this together, Dr. Majid for putting this wonderful webinar together. The sponsors, of course, and Dr. Omnia, thank you so much. Dr. Ankita, always a pleasure. And thank you all for attending. Thank you so much.
It was a pleasure having you all, and it was really nice to organize this event. great thanks to Mondi Pharma for sponsoring this event, and hope to see you in other webinars, inshallah.